Adrienne, over to you.
Sure. So I'm going to introduce this next panel. I'm talking about moving. This panel is a very moving panel because it addresses perhaps the biggest gero-cultural issue of today, and that is isolation, environmental safety for our mature population, and what it will be like for us. And no better moderator than Lucy Rose, who's the founder of Lucy Rose and Associates. She is a trainer and a communications consultant for the pharmaceutical industry. And if you heard Dr. Stein, she at one time was the director of the Office of Training and Communications for CDER, and the winner of 2 accolades from the FDA, their highest award, the Award of Merit. But she is really here as moderator because of her passion project, and that is the cost of loneliness. So take it away. Cannot wait to hear what you have to say about this very significant issue that has been illuminated by COVID very sadly.
Yes, it has. And thank you for that kind introduction. I'm really pleased. And I just want to say, I'm sorry I jumped the gun just maybe 30 seconds in advance by showing too fast a video, but I was actually overly excited, Adrienne, because I have the great pleasure of, this is my 3rd time I've actually spoken at all of these. And I just want to say congratulations to everybody, because it's remarkable how far this has come in 3 very short years. So Zan, I hope you're still listening, and kudos to you and to Joe I saw, and to everybody else. And Joe, I'm delighted to talk with you about promotion whenever you might want to do that as well. So wonderful. Lastly, Peter, thank you for your really enlightening information on registration and where that's going. I'm going to kind of move us away right now from drugs. All of you all in the previous panel talked about prevention as well. And so we're going to move now into kind of the area of prevention, and what could that look like, and social awareness and social wellness, and the impact of those kind of drivers on health span, and what it's like to try to maintain health as long as possible in one's life. So we're going to look at this through somewhat of a different lens, not looking at it through the lens of a drug, but really looking at it as how might we socially and in other ways begin to think about prevention of this even before we might think about the need for drugs. And so I'm going to move in, and it feels very, Adrienne, really thank you for asking us as a panel, and I look forward to introducing the other panelists on this as well. But it feels like this fits very, very perfectly in the overall goal of this particular Metabesity conference, which is accelerating the translation of geroscience into real material and equitable gain, especially that equitable gain piece and the material piece. What if we could actually help facilitate health span through prevention from the time a person is born all the way through their lifetime? So if you will, if you'll cue up my slides, I'm going to use loneliness as an example of one of those kinds of drivers so that we can kind of get this started. And I'll be giving a little bit on loneliness, and then I'll be delighted to introduce Amy Jeffs, who actually will be talking about potential early warning signals and what she might can use to, or what is available out there for that. And then Dan Belsky will come on from Columbia University to talk about some of the other kinds of potential social and environmental determinants. So if we could cue my slides up, I would be ever so grateful. Okay, it looks like they don't have my deck, so that's simple enough. I'm going to see, do I have, is there somebody that could give me control and I can just bring them up myself? Is that a possibility? Or if not, that's okay. I'll just talk without the deck. It's really not a problem at all. Let me just go through this real fast. First, I just want to say, yeah.
You have the ability to screen share.
Do I really? Okay, fantastic. Thank you so much. Let's see if I can do that then. I apologize. I did not plan on doing this. I clearly thought I had sent those, but that is okay. We'll just do it real quickly right from here. Ha, the beauty of technology when it works, right, guys? So here we go. The cost of loneliness. What I just want to do is just very briefly, in the next 5 minutes, give you just a feel of why this particular driver is so important in terms of trying to prevent the issues that aging in itself may cause in this kind of a concept. So whether you knew it or not, loneliness actually may be a more significant health factor even than obesity, smoking, exercise, or even nutrition, okay? And in fact, studies have shown that the impact is as great as actually smoking about 15 cigarettes a day. So the impact of loneliness itself can be huge on the physical pieces of our being as well as the emotional ones. And in fact, 35% of all adults over the age of 45 measure as lonely on the UCLA loneliness scale. And you know, the other piece that's, I want to make sure that I connect the dots, because we talk a lot about the elderly as we think about metabesity, and we think about our drugs, and we think about the chronic diseases that have already kind of taken hold in our body through geroscience and through the natural aging process. But loneliness actually starts very early in life, or can, because it's not necessarily what people think it is by definition. And in fact, young people between the ages of 15 and 21 are actually more likely to feel lonely and be impacted by loneliness than any other age group, which is a little known factor. I want to take just 1 second and tease apart loneliness from isolation. It was interesting, of course, Adrian talked about the impact of COVID, and of course it is impactful, not only from loneliness, but particularly from the whole concept of isolation. But it's different than social isolation, because some people, just to make it really easy, actually prefer to be alone, as you all might know. They're fine with having a few friends, they enjoy being by themselves, they feel healthy. But loneliness itself is really a feeling. It's having it is not having your social need for relationships met. It's that difference between what you need and what you have. And just a quick example, when you think about Thanksgiving coming up, there'll be people sitting at tables for Thanksgiving, surrounded by family and loved ones who still feel lonely, even in that kind of bubble that we create for ourselves. Now, what has happened to change the situation of loneliness? How has it changed over the last several years? Hugely. Excessive social media use, as you guys know, decreased organizational memberships, fewer and delayed marriage and partnerships, increasing working from home. Heaven knows COVID has clearly played a real role in that as well recently, taking us away from our normal work environment and all of that that's available to us. So lots of different things in the last 20 years have changed it. And how does that impact health to move us forward? And how might taking care of loneliness earlier help us with that health span? Well, clearly academic research and just an onslaught of headline news have shown us, lots of research, that loneliness is a leading driver for suicide, addiction, bullying, obesity, gastrointestinal disease, even metabolic syndrome. Joe, I heard you mention that, saying it's kind of an outdated term now, but still it's certainly one that we use and we all understand and know. So the question I have is, as with smoking, should we treat the symptoms or should we actually treat the issue? Loneliness, obesity, and type 2 diabetes are a growing epidemic, clearly. The cost is monstrous to us, hence the cost of loneliness. There's frankly no way to weigh the cost to the individual, clearly, and their families. But if we look at the mega cost, the overall cost to society, an 85% increase in cost in just 6 years on the US burden, from $322 billion in 2013 to now. Human cost, as an example, 30.3 million Americans have diabetes, making that 1 in every 11 Americans. It's monstrous. And I don't need to tell this group real fast to help set this up for Dan too when he takes over. It's clear from all indicators that loneliness could be caused by stress, but what we really know is loneliness itself causes stress. Stress causes that release of cortisol, which helps cause inflammation, which has a very fundamental, foundational, genetic, metabolic impact. So clearly loneliness is a cause, not the only cause, but a cause of some of these metabolic disorders. And one of the other issues that's huge right now in thinking about loneliness, but particularly with COVID, is that folks that are lonely often also turn to soothing behaviors, such as binge eating or addiction or suicide. I believe it is probably very reasonable to assume that these are being hugely exacerbated, often behind closed doors, even during COVID. And when we come out of this, things unfortunately will be better, not worse, all of which again increases the odds of a premature death even by 26%. So what are the current costs? Suicide costs the US approximately $51 billion annually. Substance abuse costs the US approximately $700 billion annually. And if you look at all of these together, we're talking up to $960 billion. And lastly, what's happening with COVID? I mentioned it just a minute ago, but just to set this up for us as we move forward, and hopefully for Amy as she looks for some solutions and some early warning signals. It's causing increased stress. Certainly the loss of jobs just in and of itself is a starter of that. We are seeing increased suicide, especially in those 18 to 25. 1 in 4 have been thinking about suicide, twice as many as just in 2018. Increased addiction, increased physical impact, and particularly here especially, all ages are impacted. This is not a condition of the elderly. So what do we have to do? We have to think loneliness first. We really need to use this as a marker to help with that health span. Tell the story, help educate people about the impact, and advocate. And we'll talk about advocating again when Dan comes up as well. So I leave you with this from my perspective. We live in a society bloated with data, yet starved for wisdom. We're connected 24/7, yet anxiety, fear, depression, and loneliness is at an all-time high. I believe it is vital that we course correct, and in doing so, it honestly will help us with that health span by preventing a lot of what we already are seeing. We can't afford not to. All right, and with that, you can take off my screen share, and I'm going to bring up Amy. Amy, I'm delighted to introduce you. Amy's going to, I know she will, give us a real good feel. Hi, Amy. Now I can see you. How are you? Good to see you.
I'm good.
I'm going to throw this to Amy, and I'm really delighted to introduce her. She's the Vice President of Status Solutions. She's had a lot of positions there with a mission-based organization. She's been with them for 13 years, which is remarkable in today's world, Amy, to be with any place for 13 years. So kudos to you for that as well. But she's going to talk with us. They've done some just incredible work and what Amy loves to call an early warning system, which I love that. She's going to talk with us about some very innovative ways they and others are looking at data and beginning to measure that as potential predictive ways to look at some of these societal determinants that we can be able to help prevent with better knowledge. So Amy, I'm going to turn it over to you. Thank you.
All right. Thank you so much, Lucy. I just want to double check on my side. Can we see the screens? I'm having to share mine as well. First of all, thank you. Thank you for including me today and for inviting Status Solutions to be a part of this collaborative conference. We're excited to participate and to be a part of it. As Lucy pointed out, our mission as an organization is to create what we call situational awareness, which is the ability to have the information that any organization or any individual needs in order to be able to what we call defeat ignorance-based loss. And so a lot of the things that Lucy was talking about in terms of loneliness and stress and some of the primary indicators of chronic disease over time are those examples of loss. And so what we want to be able to do and talk about today is how to incorporate technology and a platform into the solutions that we are challenges that we're trying to solve. we do not believe, and I don't think anyone involved in this conference believes that technology is the answer to everything. It is not. It is a piece of the puzzle, and hopefully is a piece of our puzzle today to work towards the outcomes that we feel we can knit together as a society and as a community, really, to help one another. And that is the purpose of utilizing a platform of technology that would then allow us to get to the point of prevention. And so talking about some of those early indicators, how to capture those early indicators, which can lead to some type of an intervention, which will then hopefully lead to prevention. We do not have all of the answers. We have a lot of the questions around how we do that, how we collectively do that, how we collaborate on that. I think some of the research and the project that Lucy has done gives us tremendous insight into the things that we should be looking for. And so when we talk about prevention and some of these outcomes that we're trying to prevent in terms of loss of life, property, business, and convenience, all of these things, all of these outcomes, we are able to create awareness around. And so if you think about it from a technology perspective, think about within either an organization or within a business, the ability to take your surroundings in terms of what's managing your buildings, what information do you have available to you? There's sensors, there's screens. Lucy was talking about screens before and how they've taken over our lives for the good and the bad. But taking that information and using those for good, using those sensors that can help to look at some of these indicators, and taking those screens and using them to provide vital information. And what we believe is that once that vital information is provided, then we can work towards an intervention and a prevention strategy. And again, those strategies involve human engagement and human intervention. We do not, at this point in time, we might get there eventually in terms of having, other types of intervention, but we truly believe that there's a human element to everything that we do. And while technology is a vital piece, and being able to create that overall platform, we absolutely believe that notifying and making humans available and aware is important. And when you think about the chronic illnesses that we are trying to prevent and get way out ahead of right now, they really do play in this idea of life safety, security, what's going on in your environment, and then who do you need to be able to notify of that information. So as Lucy indicated, this is we are talking about life safety. We are talking about improving people's lives and hopefully saving people's lives. And that isn't in just an emergency situation, because a lot of the early indicators may not necessarily be emergencies in the moment, but as time goes on, if patterns are established, we can then determine, okay, this is eventually going to become an emergency situation, if not dealt with in time. So if you think about this idea of right now, I think we're, I speak a lot about how we have an on-demand generation. I want information right now. It is available to me right now. I can go get it right now. There is no waiting. This idea of real time, give me the information. While that is absolutely important and that is a reality, if you think about time as incremental periods of right now, you can also go back in time, and being able to capture what has happened previously to then be able to draw conclusions about what is happening not only now, but predicting the future. And again, this whole concept of AI is, the buzzword, right? The buzzwords. But this idea of using that information and then being able to draw the necessary conclusions, but to enter in at a point of intervention. So truly being able to take the data, being able to leverage tools. If we let's talk specifically about activities of daily living. So if you think about the very young and the very old, the two constituents in our society who are the most vulnerable and therefore need our attention. Not that everybody in between doesn't matter, we do. But if we think specifically about the very young and, like I said, the very old in terms of what their activities of daily living are, and then how we can look at those and draw conclusions around them. So looking at, social interaction, looking at activities, are you involved? What are you involved in? Eating, health, nutrition. These are all indicators that can be captured through technology, through sensors and screens and all of these types of things that we utilize on a daily basis. Taking that information, creating baselines, and then being able to determine, okay, based on this information, I'm starting to see changes. And when I start to see those changes, those are the ways that we can then lead to taking that information, looking at what those changes are, looking at, okay, we need to intervene in this area because of this information, and then hopefully we are able to prevent. And again, yes, technology is a huge piece of this, but it is not the end all be all. That human interaction, that human engagement piece of this is just as important as laying the groundwork for gathering the data to make the predictions in the future.
Okay, thank you. And we'll come back to that, but thank you ever so much. So Dan, you're up. I don't know about your slides either, my friend, but I really am excited about introducing you. I think it's fabulous. Dan actually is a neighbor of mine and we can't wait to have lunch, but he's currently an associate professor of epidemiology at Columbia, and he is doing research clearly in aging. So he's not doing the epidemiology of COVID right now, like so many others are, but his work builds on evidence that processes of accelerated health decline and aging processes have their roots much earlier again in the life course. And he primarily focuses on cohorts of children and young and midlife adults, as well as older adults, to better understand how genetics and the environment combine to shape biological processes of aging across the lifespan. I can't think of anything more interesting, especially right now again, as we're in COVID, which is, impacting everybody from an environmental standpoint, but some more than others as we look at equity, as we talked about as a focus of this conference. So without further ado, Dan, take us, let's go.
Oh, well, thank you, Lucy. Can I just get a quick thumbs up from you that you are now seeing in full screen view my PowerPoint presentation?
Yes.
It looks good? Okay, wonderful. So I'm gonna try and pivot off of Amy's introduction to thinking about early warning systems. And I'm also gonna talk about early warnings, but really over a time scale of decades rather than what might be ultimately weeks and months. And I'm going to begin with a bit of what may be review for those of you who've been paying attention over the course of this very exciting day of presentations. Perhaps going back to the beginning of the day, when you were introduced to the idea of aging as a biological process. And I'm going to introduce this idea because it's going to become important to how we think about the accumulating effects of the environment and what we might do as a society, as a policy apparatus, as clinicians and program developers to intervene on that process of aging, again, with the goal of preserving and extending healthy lifespan or health span. So as a biological process, we think about aging as this gradual and progressive decline in system integrity. It affects all the organs in our body, and it's thought to arise, as you may have heard earlier today, from an accumulation of molecular changes that occur within and between our cells. And some of these are depicted on the two images at the bottom of this slide. I'm not going to delve into the specifics here for you, but feel free to bring this up during the Q&A. there are a range of these molecular changes. Sometimes they're called hallmarks or pillars. And as you'll see in the figure on the right-hand side of the slide, what's important to recognize about these different molecular processes is that they are connected to one another. So as one changes, so the integrity of the structure changes. And that's one of the reasons that researchers are thinking that pharmacologic interventions that modify one of these particular pillars or hallmarks may have effects at the systemic level, visualized to some extent at the top of the slide. So I'm going to move on. This cartoon here represents this idea of geroscience that we've been hearing about throughout the day. This idea that these molecular changes occurring within and between our cells feed forward to drive changes in the integrity of the organ systems in our body, which in turn are proximate causes of functional decline, disability, emergent chronic disease that ultimately disable and kill us. And the idea is, of course, that we can intervene, perhaps at the level of these molecular changes, to forestall this decline in system integrity, to prevent that decline in function and the onset of disease, and extend healthy lifespan. And you've, again, heard throughout the day about a range of different so-called geroprotectors that are being investigated. These include sort of compounds that are relatively more exotic. The Easter Island monolith is here to represent the drug rapamycin, which we currently use to prevent rejection of organ transplants, but which researchers like Dr. Kaberlein, who spoke earlier today, are investigating as a novel therapy to slow the pace of aging, to drugs that are familiar to many of us, like metformin, now used to manage type 2 diabetes. And Dr. Barzilai, who spoke earlier today, is now investigating as a therapy that can modify biological aging. Senolytic compounds that clear senescent cells from our system, a range of supplements like these NAD+ targeting ones marketed by Elysium, and of course, more natural processes, phytonutrients, such as you might find in blueberries, caloric restriction, or even, as was foreshadowed in Lucy's presentation, this idea that social engagement, connection between people may actually alter our systems at the molecular level, preserving health span through slowing this pace of biological aging. I want to talk now about how this idea of geroprotection translates when we begin to shift our thinking from aging as something that happens at the end of the lifespan, depicted here. This is how I thought about aging as a graduate student initially, when I encountered the idea something can happen to us at the end of our lives. It's what made us frail and disabled and ultimately killed us. But in fact, we've known for quite some time that what happens to us at the far end of our lifespan is powerfully conditioned by exposures that accumulate from the very earliest stages of life. So this being the Metabesity conference, I would assume that many people are familiar with the work of Dr. David Barker and his colleagues to illustrate how exposures in utero, in particular undernutrition, intrauterine growth restriction, can lead to the onset of metabolic and cardiovascular disease in midlife, ultimately driving this accelerated process of aging. But we know from a range of disciplines that exposures extending across the early years of life affect our risk for multiple different chronic diseases. And the graphs on the far left of the slide are from a paper a group I was part of published in Science earlier this year, illustrating the relationship between ACEs, or adverse childhood experiences. These are things like abuse, neglect, problems in the home, with the time of death, and also the incidence of multiple different chronic diseases affecting various organ systems throughout the body. And what's critical about this elaboration of the model of the determinants of aging extending backward across the life course is that it implies a novel opportunity for preventive intervention that we've been thinking about. This idea that perhaps this process of aging is the link between our accumulation of exposures from the beginning of life and the incidence of disease, disability, and ultimately death at the other end of the lifespan. And because it will not be possible for us to uniformly prevent all of this adversity, these geroprotective therapies delivered in young adulthood and midlife may provide a novel means of slowing aging rates and extending healthy lifespan. But increasingly, it's becoming clear that the effects these exposures have on the process of aging may become manifest in our physiology, in our biology, quite early in life. And so I'm going to show you a little bit of data, and then I'll mention briefly what some of the implications might be, and then I'll get out of your way and let us get on to the discussion. So here are the data, and forgive me, there are lots of colors and images and so forth on the slide, but I'll try and make it as simple and straightforward as possible. Let me first begin by orienting you to the simple way we've tried to measure the rate of aging in people, and this is by tracking changes in the integrity of multiple organ systems in their bodies over periods of time. And when we do that, we can observe that there are coordinated changes occurring across multiple different organ systems, even in young, healthy people. And that's generally what's being illustrated in that sort of bow tie looking graph in the top right of the slide, is that across all of these different biomarkers, we see changes indicating a decline in function, which in the case of the graph is an upward slope, as the people in this study age from the ages of 26 to 38 years. And the reason I'm orienting you to these data is we were then able to look back in the lives of these people, about 1,000 who were born between 1972 and 1973 in the city of Dunedin in New Zealand. And they had been followed since birth. And so we knew a lot about their exposure to adverse childhood experiences. And we were able to use these data to ask the question, can we see the impact of these early life exposures already by young adulthood, midlife? That's what we're looking at in the case of this study. And so in the sort of purple pictures on the bottom left of the screen, you can see relationships between a range of early life factors and this pace of aging, indicating faster aging in people who have had harder early lives. So kids who grew up in poverty, kids who were exposed to more adverse childhood experiences, and kids who were showing signs of poor health already early in life. We then have recently done some work to translate this organ system change measure, which requires a substantial follow-up and lots of different measurements, into a single time point blood test based on DNA methylation marks. These are chemical tags on the DNA sequence that are modified by the environment. And what you're seeing in the middle graph are data from 18-year-olds. Here illustrating that these epigenetic marks indicate a faster pace of aging in kids growing up in low socioeconomic status families, and in kids who have been victimized early in life. And then most recently, we have some data published from a study of children based in Texas showing that already by middle childhood, that is within the first decade of life, we can see signs of this more accelerated biological aging in kids growing up under conditions of socioeconomic disadvantage. So the idea that these environmental differences are becoming biologically embedded as a faster rate of aging early in the life course. And so the implications here for us are that as we think about what we can do to extend healthy lifespan, we may need to consider interventions not at the pharmacologic level, but in fact at the policy and program level, where we're seeking to improve the conditions in which children are being born and in which they're growing up. And there are just a couple of examples here of both social programs like TANF, interventions like the Nurse Family Partnership that already exist, as well as some investigational social programs, such as MDRC's Conditional Cash Transfer Program, and work rewards, where we're beginning to investigate potential impacts on biological aging and phenotypes consistent with a metabesity construct on toward these ideas like allowing people opportunities to move across neighborhoods or even providing basic income supplements. So with that, I'll give it back to Lucy and get out of the way so we can start the discussion.
Wow. You guys have raised just the most incredible thing. I wish we had all afternoon to talk about these. For me, we might need to do a separate conference just on these kinds of issues. Dan, just a quick follow-up. You just mentioned several different options of things to explore from a high-level perspective in terms of policy and what that might could look like. I hate to always ask folks for recommendations or thoughts, but as you know, all of the resources are limited in our world, and it's hard to get people focused on things like preventing these kinds of things because they don't get the same attention as it does when you're actually already ill, if you know what I mean. If you had to wave a magic wand and look at the pieces of your research or what you're finding with all of this, and choose one or two of those. Are there one or two that jump out at you that might make the largest impact if we could all advocate in trying to make this world better?
So if I had a magic wand, you know, what is the one thing that I would do? I guess I tend to think that making specific recommendations to policymakers is a little bit above my pay grade, but from where I sit, the interventions that are likely to be the most impactful are those that improve conditions for young women who are pregnant and who are becoming mothers, to provide increased stability and security for their families, and reduction in adverse environmental exposures those families encounter. And those include environmental toxicants like air pollution, like lead in paint or water, and interventions like the nurse-family partnership, which attempt to pair, in the case of this intervention, first-time poor mothers with a nurse who can help them understand the risks in which their family is embedded, and also the range of social services that they can access can prove very effective in preventing some of the most severe early adversities. But I think that stepping back from specific programs, I would be inclined to advocate for more general interventions that simply aim to provide more resources to these at-risk young families, perhaps in the form of what we call now unconditional cash transfers. And that might be something like temporary aid for needy families, the TANF program, but it might also be like some of these programs that MDRC is trialing here in New York, where you're sending checks or cash cards to families to help them manage the challenges that they face as they see fit.
You know, Dan, when you talk about the environmental impacts, I was struck this summer, and I'm sure you were here too, because it was all over the news here in New York, about the impact of something that so many of us take for granted. And that's the actual impact of lack of air conditioning, even in so many of these folks' homes, especially those with younger children and clearly with, you know, a challenge of income and what that looks like, and how it sets people back and really is much bigger than most of us have any clue about. The environmental impacts on all of these do set that stage. So starting young is probably a wonderful idea in terms of how to begin thinking that. Very different than how we primarily think of metabesity, to your point, is that towards more the middle and end of life as opposed to the beginning. And Amy, just to bring you in, as I think about what you do and the potential of what you may have. Clearly, some of these are mega societal issues, and how do we deal with policy, and what does that look like? But do you see a role for any of the measurements and data gathering and things you do as early intervention, and what might any of those whole restraints or constraints perhaps be in terms of privacy issues or getting into homes or age or any of that? How can you make an impact with data?
It's interesting because, as Daniel pointed out, if you look at, you know, those of us that work, you know, in healthcare and in education both, can see that there's a continuum of care that really starts at the very beginning to the very end, quite frankly. And so if you looking at what that lifespan looks like, and that as a child, the majority outside of the home of the impact that they're surrounded by and the influence is at school. And so having the tools and the mechanisms in the school facilities as well as in the classroom to be able to, again, you know, ensure the safety and security piece, but also the mental health and well-being piece. And so, yes, there are absolutely, you know, guidelines and ideas around privacy, which is very important. But I think that's where we also get into what components of this are based on that capture of data and technology, and then what pieces of this are based on observation. And a school counselor or a parent or a guardian or a teacher or an administrator or a coach being able to make those observations and then be able to match that up against the data that's being captured as well. And so then from an intervention perspective, we can start very early on. To Daniel's point, we can make those influences earlier in life that will eventually impact later in life. as well.
Lucy, we have a very profound question from the audience. We have many questions, but this one I want to take time to have you answer. And that is, a case was made by you and Daniel that we have to look at loneliness not as an issue of aging alone, but for younger. On the other hand, we have Amy, who has a lot of data, particularly from senior residences. Is there a way to break that silo so that people looking at aging and loneliness can share with people who are looking at being younger and loneliness, and really make this a new kind of coalition, that loneliness is not a matter of a particular demographic? What would you say to that?
Yeah, and folks are already doing that in other parts of the world in particular, but some here as well. The Netherlands is a real leader in some of that by really pairing young people and nursing home residents. And in fact, some nursing homes here or extended care facilities now here as well are actually providing apartments for younger people, for folks in their young 20s and things like that, for free. And all they have to do is agree to live for free in a place like that and interact and be a part of and help, bring life to the elderly folks that are living there and work as a team. There are a lot of people that are trying some very creative ideas to bring those two groups together all over the world right now and recognize that as an opportunity. Amy, you want to jump in as well.
Well, that intergenerational engagement piece is absolutely key. And whether that is, the coexisting in terms of living, but also the help that can be provided. If you think about technology and the digital divide and the adoption of technology and some of the tools that we're talking about that we use to connect right now during COVID, what we're using right now, and to be able to, what we believe is that connecting the juniors and the seniors is very important, because it not only allows for that, that human interaction, but it also prevents loneliness on both sides of the equation and can help in that area.
One of the questions that someone else asked is, could we talk about the relationship between loneliness, technology, and the use of texting and distancing communications, which I think is just a great question. That in and of itself is a fairly significant answer, but it clearly has pluses and negatives, right, Amy, as you look at this. Some of the pluses are they do connect us. Some of the negatives are we can spend a lot of time there and it's not nearly as authentic, though it is helpful. Any thoughts there before we leave? I know we're bumping up on time. Dan or Amy, any thoughts about technology and texting or distance communication and how effective that is in connecting us?
I think from what I'm reading about it, there is really a sort of evidence in both directions. In other words, that there is some evidence that technology is a poor substitute for in-person interaction in some settings, but also that it really does provide an extraordinary opportunity in others. It provides opportunities not just for person-to-person interactions that can facilitate social connection, but it's also been a real lifesaver in the context of telemedicine in connecting patients with clinicians and providing new modes of access for lots of people to get to care providers of a variety of types at a time when physical contact may not be safe. So it does seem like, like so many of these other, like any technology question, it sort of comes down to how it gets used and whether it's going to be beneficial or not.
Yeah, and one other quick question I just note before we're out of time here, but where does the suicide rate during COVID come from? I just wanted to answer that one briefly as well. It came from a study that the CDC did and released that actually the study ended in June. So it's a fairly recent study looking at the recent impact of COVID. And so you can look that up online. I don't have the exact reference right here, but it's a CDC study.
I want to thank you all. I mean, it's so difficult to take a wonderfully huge topic like this that is so profound right now and cover it the way you did. So I thank you so much.